And Paul, while we're waiting, I'll just introduce you to Alice Stewart. She is our clinical director of newborn services.
Hi, Paul.
Hi, Alice.
So there are two,
Paul.
Paul and Paul.
Atuona, I would think that the meeting invitation has been widely disseminated enough.
Yeah, we have enough. I think I'll make a start. We have enough people, I think, already.
Yep. Okay, great. Thanks.
All right. It gives me immense pleasure to welcome you all to this special seminar. Before I start the seminar, I just want to acknowledge the traditional owners of the lands we meet. Paul and Paul, in Australia, we like to acknowledge our traditional owners of the land we meet wherever we are meeting from, and acknowledge and pay respects to their elders, past, present, and emerging. So thank you all for coming to this special seminar. It is my absolute pleasure to have Professor Paul Clarke from England, Norwich, is it, Paul, in Norwich? And Dr. Paul Cawley, who used to work in Norwich but is currently at Evelina, London in the UK, to present this special seminar on delivery room cuddles. I came across this in a journal article, I think end of last year, December 2020, and I was just intrigued, and I thought, oh, it'll be good for the authors to present to us of what this concept is. So I have no idea what it was. I've read a bit of the article, but I'm hoping they'll shed some light on that. So whenever you're ready, Paul, you can start sharing your screen and we can go.
Thank you very much, Professor Malhotra. It's a real honour and pleasure to return to Melbourne, actually. I've only been once before, and it's nice to visit virtually. It's 20 years ago since I was last there. So thank you so much for the invites. We're really honoured to present to Melbourne. So thank you for your interest. So we're going to talk about delivering cuddles for extremely preterm babies and their parents. So as Atul said, I'm a consultant neonatologist in Norwich. So I'm going to start by defining what we mean by delivering cuddle. We're not talking about direct kangaroo mother care for extremely preterm babies. In very simple terms, we're talking about giving the chance for the mother or father to cuddle their preterm newborn before the baby is admitted to the neonatal unit, and our facilitation of that. So it's also known as the birthday cuddle, and we call it the delivery room cuddle because it's usually invariably happening in the delivery room. And what we mean is we're allowing the parents to cuddle their baby in their arms, or with the mother having the baby on her chest, instead of just showing the baby to the mother. So it may appear only a relatively trivial event to some healthcare professionals, but actually to parents, it's a really huge event in their life and in the life of the preterm baby. We need to remember that. So it follows the initial resuscitation if the baby's needs that, or more usually the stabilisation. In our current practice, it's typically around 5 to 10 minutes. In some instances, it's only a few minutes. Sometimes it's only a few seconds. It'll depend. But in the usual case, it's up to 10 minutes in our practice. We try and practice it wherever and whenever possible these days, and irrespective of birth gestation. So our current talk today will focus on the practice of offering the delivery and cuddle for extremely preterm babies. And I'm going to start and end this talk by you hearing from parents themselves about what the delivery and cuddle means to them. So let's start by hearing from Emma Allen, who's one of the co-authors of the paper with myself and Paul.
They say from the first time you hold your baby, you will never be the same. Your life changes. The love you feel and the emotion is overwhelming. When you have an extremely premature baby, you wish with all your heart that you could experience that flood of emotion the moment they're placed in your arms. You would give anything to hold them the way you have dreamt. Most mums of premature babies don't have the opportunity. They may have to wait weeks, months, or may never get to hold their baby while they're still alive. At 23 weeks pregnant, I was expecting twins. Charlie was shown to me and taken away to the neonatal unit as I was still in labour with his brother Jack. Jack had a more difficult birth, and it took some time to intubate him. This was extremely distressing for us. Once Jack had been stabilised, the consultant asked me if I would like to hold him before they took him to the unit. I instinctively knew this wouldn't be something I'd get to do again anytime soon. Holding my baby in my arms was one of the most special moments in my life. He was so tiny, so perfect in every way, and never in my life have I been so proud and felt so much love. I was completely overwhelmed with emotion. Would any mother turn down the chance to hold their baby for the first time? Jack died from an infection after only 11 days of life. The only other time I got to hold my baby was as he died in my arms. I still find it difficult to speak about to this day, but the cuddle I had when he was born is something I will treasure forever. Jack's twin brother Charlie very nearly didn't survive. It's been a long journey to get him where he is today. He's a happy, healthy and crazy little boy with so much character. He's now 14 years old. Since the birth of my sons, I've been told that being able to hold your premature baby isn't something that every consultant offers. And to be honest, this surprises me. I needed to tell my story to raise awareness about just how much that first cuddle means as a mum. 14 years later, and this still isn't common practice.
So 14 years later and it's still not common practice. Powerful words from Emma. When we're talking about family-centred care, we really need to bring it right back to the beginning. We're in an enlightened era now. We know that optimal health outcomes are achieved when the baby's family members play a direct and active role in providing emotional, social and developmental support. And that active role of parents in providing such support can and should start right from birth for all parents, all babies. Enabling the delivery and cuddle, I think, is the ideal way in which we can promote a partnership between parents and ourselves as the healthcare professionals in the care of the premature baby right from the very outset. And if we allow mums and dads the chance to cuddle their baby before the neonatal unit admission, it begins that partnership and can have many benefits. So the practice is feasible, it can be done safely, and it is beneficial. And we believe it can and should be practiced for most babies born preterm for their benefit and benefit the parents. So it's just a couple of days since you had your journal club with this groundbreaking research showing that immediate skin-to-skin contact is life-saving for babies. So this was a study you have presented just a few days ago showing that babies between 1 and 1.8 kilograms, if they received early skin-to-skin care with their mothers, they had a highly significant difference in the chance of survival. And the conclusion was that given these early skin-to-skin would significantly improve survival. So we've got amazing evidence from this study published in New England Journal of Medicine. But that's direct skin-to-skin for more mature babies. We're talking about extremely preterm babies. Could these benefits still be seen or be possible with delivery and cuddles? Well, we already know the benefits of direct skin-to-skin. They're multifold and include physiological and behavioural benefits, including better thermal stability, better sleep, better breastfeeding, early discharge, and better growth of the babies. There are also psychological benefits to the parents as well, with less stress and better bonding. So while for the extremely preterm babies, the delivery and cuddle as we practice it does not usually involve complete direct skin-to-skin contact because the baby is inevitably in polythene bag and swaddled in blankets, we believe that some of the benefits may well be similar. We've known for decades now that there's an early sensitive period in those first minutes and hours after birth, and that these are crucial for the formation of a tight bond between mother and infant. So this special period is characterized by a special neuroendocrine situation, probably mediated by oxytocin and probably also prolactin. It's a unique period of increased maternal sensitivity and responsiveness. And if we can facilitate some direct contact in that period, it may improve the quality of those mother and preterm baby interactions and increase the chance of long-term secure attachments. So why should we think about practicing delivering cuddle? Well, fundamentally, think of the parents. From their point of view, they want to cuddle their newborns. It's instinctive for them. And we know that abrupt separation and removal to the neonatal unit from a baby who's already been with the mother for more than 6 months is traumatic. And that's likely to be mutually traumatic to the baby as well as the parent. If we can give a calm and supervised initial cuddle, I think that's a marvellous opportunity for us to provide initial reassurance for parents and for them to meet and form an initial physical bond with their baby for the first time ex utero, and indeed for the baby to feel a first loving embrace. And then parents have those special moments to touch their baby, kiss their baby, and if they want, get first family photographs and video together. I think we've got a real imperative to practice it for the highest risk babies. We know it's not yet common practice, but we do know that extremely preterm babies, once they're admitted to the neonatal unit, they're immediately effectively incarcerated in their incubators. They get shackled to multiple items of equipment and it becomes very difficult to get them out, even with best intentions in those first few days. And if we don't allow cuddle of these extremely preterm babies before the neonatal unit admission, it's invariably many weeks before that first cuddle becomes possible for the majority of babies. That initial cuddle, I think, is especially important for the extremely preterm babies because they're at the highest risk of dying. We're not very good still at predicting which babies are destined never to make it out of the neonatal unit alive. It's a real tragedy. I've seen in my personal practice if that first cuddle's only offered when a baby collapses suddenly and parents are called in rushing from home and the baby's dying, or when they're terminally ill. Many parents I've seen, out of sheer grief, they cannot bring themselves to hold their baby in such circumstances if for the very first time when the baby's dying, they're being asked if they want to hold their baby. I can only guess at what consequent grief many of those parents would live with for many years to come if they've refused to hold the baby in those circumstances. So it's a real disaster for all if the baby dies suddenly, never cuddled. So why is it not yet routine practice? Well, I think we've never really been brought up to do it traditionally. We've always felt within us that and been taught that there's an immediate imperative to rush that baby round to the neonatal unit, to the place of safety for their ongoing intensive care. It's not helped that there's been absent literature effectively, absent guidance until recently, and pretty much absent safety and outcome data until very recently as well. There's actually been very few trials and none that I can see in the extremely preterm babies. There's been a lack of feedback from parents and for us actually listening to what parents want and need in the delivery room. Pleased to say it's now becoming routine practice in more and more UK centres. What we have seen is that where it is practice, it's unanimously supported by nurses and midwives. I'll just briefly mention two of the randomised controlled trials that there have been published in very recent years. So the first one from Katrin Mahler from Cologne in Germany. They studied 88 babies and they were randomised to either get 60 minutes of delivery room skin-to-skin contact with the mother, or else the other control group was that the mother only had 5 minutes of visual contact only, with no holding, no kissing and only minimal touch. These babies were randomised at around 45 minutes postnatal and that followed stabilisation with whatever the baby needed, including Lisa if they needed. They did exclude babies who were needing to be intubated or in more than 40% oxygen. And their outcome measures they looked at, the main outcome measure was an interesting one. They looked at bonding at 6 months corrected age on anonymised videos. They had them rated blindly and actually found that the maternal and infant interactions were better in the babies who'd had that early skin-to-skin contact for the first hour. They also looked at short-term safety outcomes, including temperature, and they found actually that the temperature was higher in the delivery room skin-to-skin contact babies by 0.5 degrees centigrade, and that was a significant difference. There were no other differences in neonatal outcomes or short-term outcomes. Then there's been a trial from Stockholm in Sweden, again, a very small one, but they randomised babies born between 28 weeks and 33 weeks and 6 days gestation to either get immediate stabilisation on the maternal chest after birth with skin-to-skin contact again for the first hour, or else immediate stabilisation on the resuscitator, and then the baby went straight into an incubator or cot, and there's no direct contact. So they looked at short-term outcomes here, and they found that the babies who'd had the skin-to-skin were marginally cooler at 1 hour, after whether they had the cuddle or the incubator. It's only marginal, there's a 0.3 of a degree centigrade difference, but they didn't see any other differences for respiratory support outcomes or breastfeeding. What about the extremely preterm babies? It's been my own personal practice to practice the delivery and cuddle irrespective of gestation for probably around 20 years now. I can't remember exactly when or where I started doing it, but I remember why I started doing it. Initially, it was because it was giving the babies back to the mothers when the babies were pre-viable, and it seemed only a natural thing to do to actually give the babies back to the parents for a few minutes when they were likely to survive. So we've actually practiced it in our centre in Norwich for at least 16 years now, and it's been done irrespective of birth gestation. Initially, it was practiced fairly variably, but it's much more routine now, and it's the exception for the babies not getting delivery and cuddle now in our centre. So I went back a couple of years ago and reviewed the short-term safety outcomes over a 12-year period between 2006 and 17 in the babies who had had a documented delivery and cuddle. So this was done as a case control retrospective review, and we matched babies who had a documented delivery and cuddle to those we knew the babies had only been shown to the parents before the neonatal unit admission. And just to summarise very briefly the results here, which again are presented in our paper, you can see the babies who had the delivery and cuddle, they went down as low as 22 weeks and 5 days gestation. The median gestation was 24 weeks and 6 days in the cuddle babies, and similar gestation. So there's no significant differences there. They were quite well matched for weight, gestational age, gender, multiplicity where we could. The main things we were interested in were the time to neonatal unit admission, and you can see that there was no significant difference here in the time that the babies were being admitted to the neonatal unit. And similarly, there was no significant difference in the baby's admission temperatures here. You can know that some of the temperatures were quite low. These are historic data. I'm pleased to say our data are far better over the last couple of years as we've been focusing better on thermal control. There's no difference in survival to discharge either. So the conclusions from this, limited because it was small numbers and it was retrospective, but nevertheless some data to show safety. There were no differences in neonatal unit admission times or temperatures, no differences in mortality. So my conclusion was offering parents a brief delivery and cuddle of their extremely preterm baby prior to the admission did not significantly delay the baby's admission, nor did it adversely affect the baby's neonatal admission temperatures. So I'm going to talk about which babies we offer it to. We try and offer it to most babies. Any birth gestation is eligible to be considered. So this will include pre-viable babies, and it'll include babies with anticipated severe congenital abnormalities where postnatal survival is uncertain. There are certain babies where it's probably not indicated. So obviously if the mum's been under general anaesthetic and the baby's delivered by caesarean section, it's not going to be possible in those circumstances. It often is still possible for the father who's in the delivery theatre, and we'll try and facilitate that. If the mum herself's acutely unwell or needing medical stabilisation, obviously that's contraindicated in that situation. Her needs take priority. If a baby's got an expected or unexpected difficult airway or congenital airway malformation, obviously it's not reasonable to do a delivery and cuddle in that circumstance. If the baby's needing prolonged resuscitation, for example, an urgent need for inotropic support or ongoing need for volume or blood products, then the baby wouldn't spend those minutes having a cuddle, be urgently admitted to the neonatal unit. I think there are situations where it's more challenging, but we wouldn't regard them as absolute contraindications to offering delivery and cuddle. So awake caesarean section, we can facilitate in those circumstances. For multiples, we practice it frequently, has its own challenges. And then babies with congenital cyanotic heart disease or neonatal encephalopathy, we wouldn't automatically exclude them, but they're assessed on an individual basis. And similarly for some surgical conditions as well, we wouldn't automatically exclude babies. So I've covered the who and what it's about. I'm going to hand over to my colleague Paul Cawley now, who's going to talk about how it may be done and how it may be practiced. So if you just bear with us while we hand over here.
Thank you, Paul. I'll just get my screen up. Okay, can you see the screen? Perfect. Thank you very much. Right. So yeah, I'll cover the ABC of newborn care and how to do the cuddle. So airway, breathing, cuddle. And by ABC, I hope you'll learn that it's methodical, simple, and easy to practice. Through my talk, I'll tell you a little bit about my personal motivations to start with, and then think about what the risks are, how we can manage these, and how in doing so, actually, you're generally underpinning good quality evidence-based care for your baby. So I was fortunate to come across Charlie and Jack's story. This is this story we saw at the in the animation at the beginning of this presentation, and you can see this as a case report in Acta Paediatrica, and it really motivated me to give every baby in my care a cuddle whenever it was safe to do so. And so I've come to an appreciation that doing the deliver and cuddle feels natural and right, and in the rare circumstances where it's not been possible, it certainly to me has felt uncomfortable and not right. But I'm also keen to adhere to the importance of good neonatal neurodevelopmental care, and I'm certainly aware of some of the evidence around skin-to-skin and kangaroo care in general, separate from the delivery room, to improving outcomes in our vulnerable population. So cuddling babies is not a new thing. Cuddling preterm babies and kangaroo care are not new things. You can take this paper way back now into 1991. Very small babies down to 700 grams showing good physiological stability. Alongside the recent systematic review we saw from the Lancet, there's also this meta-analysis in all resource settings, from low resource, mid and high resource settings, which shows reduced risk of neonatal sepsis, increased breastfeeding, improved pain measures, saturations, head growth, and also reduced mortality risk in all settings. There's also this great paper from Columbia, which was a 20-year follow-up of an RCT, which showed that the group who received the kangaroo care had reduced hyperactivity, reduced school absenteeism, and even when they grew up, higher wages and better job prospects. So there's a real social case there. And scientifically as well, we know that during cuddles, if you were to put EEG on these infants, you see evidence of enhanced sleep-wake cycling and electrophysiological maturation. And there's several papers showing this. The European Foundation for Care for Newborn Infants, which is a joint parent and neonatal collaborative, essentially also identify that skin-to-skin care is of particular importance for very preterm babies, and they see it as standard care that the skin-to-skin contact should be initiated as early as possible. And finally, as well, the Lancet identified skin-to-skin care and addressing barriers which may prevent institutions from undergoing kangaroo care as a top research priority going forward. So how do we practice the deliver and cuddle? Well, there are several contributing factors as to how a centre may undergo the delivery room in their centre. This will be dependent on what equipment's available, how the delivery room itself is set up, and to some extent then the relationship and distance between the delivery suite and the neonatal unit. And in terms of risks, I think probably the greatest risk from practicing this actually is related to the human factor and the intrinsic elements of the team in that respect, particularly when teams are introducing this practice for the first time or are new to it. So there may be environmental, organisational, individual factors that we need to be aware of. And it's vital that teams undertaking the delivery and cuddle have good situational awareness, have good closed loop communication, an experienced nominated leader, and a shared understanding of the procedure. And this little clip here just shows, I think, how things can go wrong in terms of human factors, where individually both of these stretcher bearers are doing the correct thing. But if you don't have that mutual understanding, a clear leader, and closed loop communication, then potentially you can have devastating consequences. So if you were to extend this analogy to a preterm baby, of course, there's risk of mishandling the infant. It may be that you don't have appropriate medical gas cylinders, electrical supplies. So human factors should be borne in mind, and actually I think are the biggest risk, which can be controlled. But there are also factors intrinsic to the infant. We of course know that preterm babies have high surface area to volume ratios. They have a lack of insulated subcutaneous tissue, wet skin, and limited means of generating their own thermoregulatory potential. So there is a risk of hypothermia. We know that there's be a degree of surfactant deficiency in premature lung architecture, which of course may lead to respiratory insufficiency and instability, and limited energy stores of the infant, and a potential stressful delivery, physiological stressful delivery, may lead to a risk of hypoglycemia in addition. So it's important to bear all these potential risks in mind in order to mitigate them and control them and deliver a safe cuddle. So we can divide the practice into several stages. Of course, antenatally, you may have some time when the mum presents in labour, or if they're planning a section, to have antenatal consultation with the parents. And I think in that case, then it's good to include the potential for the delivering cuddle in the counselling session that we provide. So they're aware of the possibility, but also aware that there are some rarer circumstances where it wouldn't be possible. And of course, for the infant itself, it's important to prepare the room, room temperature, minimising drafts, making sure that the baby's being born in the correct centre, they've got steroids and magnesium on board, and any potential complications are identified at an early point so they can be controlled. In terms of birth and stabilisation, this should be pretty standard practice actually, and most centres will have their own early stabilisation guidelines, and of course there are national and international resuscitation guidelines. But essentially, you should process this as normal. There's the opportunity for optimal cord clamping, making sure that the baby's respiratory and thermoregulatory means are tended to, so plastic bag, hat, and then establishing monitoring for this infant, which I think temperature monitoring is really vitally important, continuous saturation monitoring. If they're intubated and have a definitive airway, then end-tidal CO2, or otherwise, if their primary respiratory mode is non-invasive respiratory support, then setting up a definitive interface, nasal CPAP or high flow gases as per the centre's preference. And of course, if they need delivering LISA or surfactant and stabilising this baby to a point that they're in optimal condition. Once they're stabilised, it presents the good opportunity to assess if they're suitable for a cuddle. And this is a little checklist which is included in our paper, where you may consider babies for cuddles. So making sure that we're saturating them, we've got a stable heart rate, critically that we've got a good temperature. If you're going to start off cold, you're going to finish cold. So temperature monitoring is really critical here. And as I said, making sure you've got a stable interface for managing this baby's respiratory needs, whether that's invasive or non-invasive. Some of the cautions and contraindications that Paul Clarke's already been through, and just to re-emphasize there in red, making sure that we're happy with this baby's temperature before we start the cuddle. It's important as well to prepare the surrounding team. It may be that the midwife and anaesthetist obstetrician has never seen a preterm baby being cuddled, and this may be an alien concept, so they should be prepared. And if they're on board and are aware, they'll often be able to facilitate some of the logistics around this cuddle. So making sure the space between the baby and the mum is cleared so you can bring baby over, and also making sure that they're happy that mum's stable for the cuddle as well. Updating parents, and some units may like to weigh the baby at this point in addition. It's really important to get the parents to be comfortable and prepared for this. So these are some of the things that we certainly like to tell them, reassure them that the team is there with them, that the baby is stable, receiving optimal care, that we're continuously monitoring the baby and we know the baby's safe for this cuddle, that the baby will be comfortable and their care will be enhanced from cuddling. And of course, this is a really unique and special moment for this family. And I think photos and videos, if that's what the parents want, can be really precious going forward. So during the cuddle itself, we need to make sure we've got adequate power and gas supply. And there's two ways of doing this essentially. You can either move your resuscitator over from the resuscitation bay over to the mum, and then put the baby on mum and continue using the resuscitator for your respiratory stability. Or it may be if you use a transport incubator, you can move the baby into the transport incubator and then move the transport incubator to mum and use your equipment that's on that. As we've mentioned, human factors are a strong area of risk. So we need to have an experienced lead and team communication. We need to make sure that that airway is secure and supervised. And then once we're happy that we're in a position to move baby over, moving them over, still in the bag, warm towels, and if you've used any heated mattress, that as well. And then continuing optimal respiratory support throughout the cuddle. So if they're on CPAP, you continue CPAP. If they're ventilated, you continue your ventilation. And as we've mentioned, assiduous monitoring, heart rate, saturations, temperature, capnography. And if there are any concerns, acting on these promptly. What else can be achieved? Well, you saw from Paul there that actually there was no significant difference in time to admission from the babies that received a cuddle and those that didn't. So there are lots of things you can do to increase your team's efficiency whilst this cuddle's on board. Certainly there should always be an experienced and skilled member of the team with the infant, but other members of the team can be getting other things ready. This may be, if you've weighed the baby, getting prescriptions done, making sure that the units are aware that you've got your incubator pre-warmed, the ventilator's ready, and your infusions and trolleys are all set up. And it may be some practices in centres to actually have cannulated this infant prior to the cuddle. And if that's the case, you can even administer the antibiotics, caffeine, vitamin K, and provide glucose substrate as well. In terms of equipment, there's no special equipment required that any neonatal unit that's routinely stabilising a baby and supporting them on the NICU won't have. So you'll need a resuscitator, and you'll need means for keeping this baby warm, standard hat, plastic bag, potentially a portable heated mattress, and control of breathing, whether that's if they need invasive support or non-invasive support. And then in terms of monitoring, lots of the bedside monitors actually have a detachable multi-monitor, which are really fantastic because then you can see all your parameters at once. You get your sats, your heart rate, your temperature, and your end tidal. So this is the monitor. This is how I generally set up my resuscitator prior to baby being delivered. So we've got our temp probe there, our saturations, and if you don't have the ability to do waveform monitoring, you could always have a colorimeter for your ETCO2 as well. Of course, if you don't have one of the detachable multi-modules, then you could just use a standard saturations monitor, and you'll find that most resuscitators actually have a skin temperature probe monitor that you can use to monitor this baby's temperature. And then there's a summary figure available in our paper, and just a kind of graphic form of different ways of doing this. You can either bring the transport incubator over to the mum's bedside and then move the baby over from the transport incubator onto mum's chest. Certainly this is my preference. It's particularly good if you've got a more sophisticated ventilator. You could continue targeted tidal volume ventilation during this if the baby's intubated. You've also got the option of a syringe driver if needed, and all your monitoring there. But of course, it's equally possible to bring your resuscitator over to the bedside. And if you've got an intubated baby and you're delivering IPPV via a neopuff, then you can continue to do this with the resuscitator. And we've got here a picture as an example of an infant receiving the deliver and cuddle with the operator delivering IPPV with the neopuff. Alternatively, if you don't have an ability to do a definitive nasal CPAP and the baby isn't intubated, some centres may like just to use their mask during the cuddle, but I think really it's preferable to get a definitive interface that works with your setup. And just really a summary flowchart there showing that there's multiple stages, in which case we're always attending to thermoregulation, provision of respiratory support, effective monitoring, and controlling the human factors at every stage. Implementing in this, this practice, I think a guideline is particularly helpful, training and simulation before implementing, practicing the cuddles for all babies big and small, and then by the time you come to the tiniest, you're well rehearsed and feeling more confident. It's important to have the whole team involved, not only the neonatal team, but also obstetricians, anaesthetists and midwives, having local leads who can disseminate knowledge, problem solve, and stoke enthusiasm. And of course, then audit and governance to ensure that this is being safely implemented. So here is our paper, which has some of those figures available and also some of the retrospective data that we've got. And I will hand over back to Paul just to close up and see a delivery cuddle in action. Thank you, Paul.
Thank you very much, Paul. So that's how to practice it. I'm going to, in the final part of our talk, I'm going to come back to parents, because this is fundamentally about parents and their baby and us making those first moments as special as we can, as safe as we can, but as precious as we can, never knowing what the destiny of that baby is or for that family. So it's really important to know what parents think about the delivery room cuddle. So we undertook a survey, it was done back in June 2018, and I went back again over about 12, 13 years to see and question the parents who we knew had had a delivery room cuddle and see what they felt about their experience. Could they remember it? What were their feelings at the time? So we present more of the data in our paper regarding this, but just to very briefly summarise some of the questions we asked and responses we got. So one fundamental question was, how important was that first cuddle to you as a mother of a very premature baby? So we asked the parents, the mothers, to rate on a Likert scale between 0, not at all important, and 10, extremely important. And these were the responses we got. So you can see there was one who was quite ambivalent, and this is a mum who, from her other responses, hadn't been properly prepared before the cuddle, and it was a bit of a shock to her. We're much better now at making sure that doesn't happen and that they know what to expect. But I think this was a mum who worried we were actually delaying the intensive care of her baby, rather than what we're fundamentally doing is carrying on the intensive care during the cuddle. We also asked, how important do you consider it that neonatal doctors, nurses, or other centres basically try to offer an initial delivery room cuddle before the baby's taken away? So what did these parents who'd had the cuddle think about whether it should be more widely offered to other parents? Again, they rated between 0, not important, and extremely important. And again, the vast majority of parents thought it was extremely important that we as practitioners should try and give parents a chance to cuddle their baby. We asked them what the first cuddle meant to them, and they could provide some free text here. So these were a few of the responses we got. We've published all the responses we got in our paper as an appendix to it, so you can read in more detail, but these are some typical responses we got. So one mother of a 26-week gestation boy said, making that initial cuddle as close as it could have been to had he been full term to make it feel normal was great. Another mum of 26 weeks said, it was incredibly important as I did not get to hold my son again for 2 weeks as he was too sick. That cuddle helped to initiate my breast milk and I was able to express and eventually breastfeed my son when he was stronger. And then a mum of a 22-week gestation boy said, considering how unclear the outcome of his birth was, I can honestly say that cuddling my baby boy was probably the most encouraging factor in me deciding to express milk for him. And we've seen that theme a lot, actually, that mums are reporting it is encouraging them to express and helping their milk production and chances of breastfeeding. So some really lovely quotes from a mum of 23-week gestation twin girls. She said, I got a cuddle with both. It was so beneficial to hear them cry and stop to have that first cuddle was what we needed, as I wasn't going to have another cuddle for a while. To have that first cuddle, I felt like a mummy. And I was very thankful because I didn't get another cuddle until 24 days later, which again was very emotional to see them and touch them. But maybe it was that first touch was what we all needed, knowing it's going to be a really tough journey ahead. I was and am so grateful to have had that first cuddle, and luckily I got the chance. I really hope this becomes the normal thing to have straight after delivering. It's such a powerful connection you have, even at that very early on time. And I feel like it's part of why the girls have done so well, because of as much skin to skin as I could from the minute I could. So I want to show you a little video clip now, just to show you a portion of the delivery room cuddle in action, and to show, hopefully, illustrate it can be done for the most premature babies, those that were borderline viability, that we're resuscitating now, stabilising now, and hoping to be able to take to the neonatal unit. So it's with kind permission of the parents of this little 22-week gestation boy that I'm sharing this mobile phone footage that was recorded on the father's camera. So this is little Nicodeme. His mum is actually one of the co-authors of our Acta Paediatrica paper. This little lad was born at 22 weeks and 6 days gestation. His birth weight was 530 grams. And this is back in July 2018, and one of the loveliest deliveries I've been blessed to be present at. So at the time the video starts, he's actually 26 minutes postnatal. All the resuscitation's already taken place, that stabilisation. He's been intubated, he's had a surfactant, he's had his delayed cord clamping, etc. In fact, his tube dislodged and he was reintubated. So that's why it was 26 minutes before he was brought over to his mum. So here we go. It lasts about 2 minutes or so.
He's absolutely fine if you want another couple of minutes. He's absolutely lovely. He's doing a bit too well, which is why I just asked him to turn him down a little bit.
We've got saturations 95.
Heart rate's 170.
Fantastic.
His temperature is perfect.
Super.
You've grown him very well, Mummy.
Thank you so much. Thank you, everybody.
Very good job there. You would have been huge if you'd gone all the way.
So it's early days. So what we'll do when we get around, we need to put some special lines in, some tummy button, so we can give him some sugar solution, and then some liquid feed as well.
Okay.
And really important will be, are you planning to breastfeed? Have you thought about that?
Yeah.
That'll be really crucial.
Okay.
Get work on, overnight, get some milk expressing, and then we can trickle that down into his tummy. Try to check the position of the lines. Here we go, minute to minute, hour to hour, and so far so good. We couldn't have hoped for a better state of him. Good weight as well. We'll weigh him when we get around. We don't know his weight yet, but as soon as we get around, we'll be able to weigh him and then let you know what it is.
Daddy, did you want to say Mummy? Did you want to go?
Let's go.
We'll be doing 90 minutes, but you can sit there and keep you
Telling you bad jokes.
So Mum's not lost a sense of humour.
Oh my god, yeah, bad dad jokes.
It's just part of being a dad. Join that club now, bad dad jokes. Dad dancing.
So special, precious moments. I hope that gives you a sense of how calm it was at the time in the room and how lovely and blessed we are to be right in the midst of the family at that really precious time. You can hear the lovely little conversations our nurses were having with the parents at the time, reassuring them all the time. And I'm busy doing the video. That's what I was doing while I was chatting to the parents there on Dad's mobile phone. So we can offer that, offer to get the photos and offer to take video. And the parents absolutely love that. And it's precious, precious memories and videos they have from it. So just to very briefly say what happened to Nicodeme, he's actually going to be 3 years old next month. So let me just stop that. He was admitted to the neonatal unit after it was about 9 minutes he spent with his mum in her arms on her chest there, and then Dad had a cuddle for about 4 minutes or so before he was then taken around to the neonatal unit. His admission observations were all fine actually. His first glucose was 3.1 at 55 minutes, and he was in oxygen even though he was still intubated at the time. So our conclusions are, we believe the delivery room cuddle is very safe with appropriate preparation, supervision, attention to detail and teamwork. That teamwork can involve simulation in practice, and so that we're all aware of what's going to happen and who's going to be doing what. And the good communication is really key to success. That's within the team, amongst the team, the wider team as well, not just amongst the neonatal team, but the midwives in the room, obstetricians or anaesthetists, they're in the room as well, making sure everyone's on board with it, and that we're able to offer it. We only have one true birthday in our lives, so we only have one chance to offer that birthday cuddle for that baby and for those parents. What we can say is that the delivery and cuddle is hugely appreciated by the vast majority of parents, especially those who will sadly end up as bereaved parents. Delivery and cuddle is feasible for the majority of preterm babies, irrespective of gestation, and we really think it should be the norm and not the exception. So just coming back to Emma, again, co-author, these are some more of her words. She says, a cuddle is so important. Being able to hold Jack right after birth meant the world to me and was so special. It's the hardest thing in the world not having your baby near you after delivery. And you hold on to that one cuddle you've had. The cuddle I had with Jack when he was born meant so much, and all mums should have this opportunity. So I'm going to end with a little video clip here from another parent, actually. This is a parent who I had the pleasure of eventually meeting, but she heard me speak I was presenting up in Newcastle in the north of England. She's a mum called Lottie who runs a neonatal charity which cares for the mental health of parents of preterm babies. So Lottie runs Lottie's Neonatal. I'd like you to hear her speak because she says it far better than we can.
As Paul said, at Run Leo's, we are a charity which supports mental health of families who have been through a neonatal stay based up in the northeast of England. I've got first-hand lived experience of being a parent without a delivery room cuddle. I'm a bereaved mum as well, so I had twin boys, Leo and Oscar, back in 2015, and sadly Leo passed away at just 4 hours old in the NICU. And I came across delivery room cuddles a couple of years ago on Twitter and immediately got in touch with Paul because I just thought, oh my God, this would have changed so much for me as a parent, because I was and always will be the parent that the first time I got to really see and hold my child was the point in which I was told he was dying. And the impact on me was so catastrophic because no one ever thinks as a parent, you know, when you get pregnant as a woman, you don't ever think that your baby's going to die, let alone that you would hold your child while they were dying. So for me, kind of, this is so important because it can change the trajectory for so many families, not just the bereaved families, but also the families that go on to have surviving, babies in the NICU. Speaking again from my own experience of having a surviving twin with Oscar, I didn't get to hold him for over 2 weeks, and it massively impacted the bond that we had because I looked at him for so long like a patient and not as my own baby. And I think if there's anything that teams can do to help facilitate these cuddles, it absolutely, in my opinion as a parent, it should be done, because when you are handed your baby for the first time and told the words that your child is not going to survive, here you go, I cannot begin to explain as a parent the devastation that causes, and to be wanting to have that moment with your child, you know, as we often see when we walk in maternity wards, the mum with the baby on the chest or breastfeeding, and it's kind of drilled into you all the time that that's how your first moment should be with your baby. And when that isn't the case, the pain is indescribable, and it's not something that as a parent, you know, or as a team, that you can ever go back and have a do-over. So it is vital that if you can offer those cuddles in that situation, then you absolutely should be, because you have the power to change the trajectory of someone's grief. You know, losing a child in the NICU is a very unique experience that comes with a lot of trauma. But if there's something that can be done, you know, beforehand in that delivery room to help facilitate, you know, a lovely moment, a moment that allows that family to feel like a family, a mum to feel like a mum, a dad to feel like a dad, you know, and that family to be united, I think you should, you know, absolutely 100% do it. I can't advocate for it enough. It's something that we absolutely love at Leo's, and yeah, I just think it's wonderful.
So again, powerful words from Lottie. It can be done. It should be done. We believe it should be done. And if you listen to parents, really, we should be facilitating it. You have the power to alter the trajectory of these families' grief. Really powerful. So I'd like to thank you all very much indeed for inviting us. It's a real honour and privilege. I'd like to just end by thanking all our nursing, medical, midwifery, obstetric colleagues in Norwich for their support over many years. Special thanks to Lottie there, and Terma and Sheila for supporting the development and promotion of this concept from the parents' unique perspective. And thanks to all the other parents who've kindly allowed us to share their pictures and words. Thanks to you all for listening in today. And I should say thanks to my son Max, who kindly subtitled Lottie's video, and I think he's listening in as well. So thank you all.
Thanks, Paul. If you can stop sharing, that'll be great. That is fascinating, very emotional as well. So Paul, I have divided the questions into 3 categories. I'm going to ask you the baby category questions, and then I'll hand over to my colleague Doug to ask you about team and environment related questions. So in the baby category questions, it's going to be a rapid fire because we might be running out of time. So the first question was, did you see any differences in the really small micro preemies, you know, less than 25 weekers, less than 24 weekers? Do you have more, I guess, challenges dealing with those babies?
I think it is more challenging the more premature the baby, but you know, I hope, coming back to that little video there, that's pretty typical. Where we've got a stabilised baby waiting to go to the neonatal unit, that's the moment to take them to back to the parent, back to the mum. So that baby is as stable as it's ever going to be for days, if not weeks, at that moment in time, and it's a really precious moment to capture and give back to the family before we just take the baby away and put it through all the traumas that we do on the neonatal unit.
Sure. What is your average time of cuddles? Is it, you said 9 minutes for that family, but normally what is your average time for a cuddle?
Yeah, as I said at the beginning, it's probably somewhere between 5 and 10 really. I think with more experience, you get more and more relaxed as the cuddles go on over the years, and I'm sure it'll increase as well. I think we'll have better data in years to come, more prospective data showing its safety and also its benefits as well. And we'll be better at monitoring all the aspects, much better at monitoring temperatures now, as Paul's shown with the continuous temperature monitoring.
And we had a question on that, Paul. What are you using for temperature, continuous temperature monitoring? Is it the incubator temperature probe you're using, or what are you using for that?
Paul, do you want to take that one?
Yeah, so here we are. So, I mean, whatever, I'd be surprised if you're not monitoring your baby's temperatures on your units. I'd be shocked, in fact. And whatever temperature probe that you have on your unit to monitor your baby's temperature whilst they're in the incubator is the same one that you can use when you're in the delivery room.
Yeah, I'll just interrupt you there and ask our nurses if we have the Draeger monitors, so we don't use Philips anymore when we move to the new hospital. Our Draeger monitors, the ones we take down team, do we have temperature continuous monitoring in that? I'll just leave it there so that they can answer that question as we go along.
So the key is just finding the right adapter. So you can see on the screen there, there's the Philips one, but also there's the Benview one, and you just need the right adapter for your monitor. But if you don't have one on your monitor itself, then the resuscitators will have a skin temperature probe as well.
Yeah, a couple of other questions on fluctuations. Kurt Duvall has joined us, and he asked about, with the small babies, we really get worried about interventricular hemorrhages with great fluctuations of, I guess, blood pressure and other vital parameters. How do we control for that? Or I guess you haven't seen any increased IVH rates, obviously.
Not at all. We find the babies are far more stable. As I say, they've been stabilised at that moment. So when we take them over, they're as stable as they're going to be. And they're actually beautifully stable in the mum's arms. We've not seen any tube dislodgements while the baby's been cuddled. As you can see, the whole team is around supervising that moment. So the baby's probably not going to have as much expertise and as many personnel at any moment subsequently in its whole journey through the neonatal unit. So the babies are really stable. They're not being moved around. They're in the mum's arms. The mum's talking to them. The baby can feel the mum's warmth as well. It's a really stable moment.
Cool. Doug, over to you for team and environment.
Yes, thanks very much. Very inspiring stuff again.
Sorry. Yep.
Sorry, I was on mute. I was just going to say thanks again for the great presentation. Very inspiring stuff. We had over 55 computers logged in. I don't know how many eyeballs that represented, but some people might drop out slowly as 2 o'clock hits. So as far as environmental goes, we've had quite a bit of issue in our center currently with temperature on admission. So were the temperature of the delivery room suites and ORs, did you change the temperature? Did you try to increase them? How did you manage that?
Yeah, target room temperature would be 26 degrees, which is actually easier in our operating theatres than it is in the delivery rooms themselves. But both have thermostats. We target 25 to 26 degrees ambient.
And so, with that being said, did you have to engage your obstetric and midwifery colleagues by making that change? And was it a slow process, or because 26 is it's up there.
It is, yeah, it is.
Yeah.
So in fact, throughout the whole region, this is a standard practice. I can't say that every hospital in the east of England reaches this temperature, but there are posters in each room which specify the target temperature for extreme preterm babies. And for the hospitals that aren't able to target or have direct control of their thermostats, then we ask them to add that to their risk register. And then I think you find once it's on a department's risk register, then management and facilities are more likely to provide that capacity to adjust. But it is hot.
Other temperature regulation items that you use, because I noticed there was one picture where it looked like a T-piece connected to an endotracheal tube, which I assume was connected to unhumidified, unheated air. Did you have thermo mattresses? I mean, you showed life start trolleys in there. Was there anything else that you used?
Yeah, I don't actually use the life starts. I just use the standard resuscitaire for the extreme preterm, and then my preference would be to use a transport incubator which has humidified gases.
Yeah.
So that's my personal preference. But I know that not everyone has transport incubators that have humidified gas available. In which case, I think unhumidified is okay, given that's what you'd be delivering to the baby when they're not having the cuddle in that room.
Sure. Great. Can you talk a little bit about staff requirements and preparation? I mean, I guess a few minutes extra in the delivery room for a 25-weeker is probably not particularly onerous on staff requirements, but was there any changes that had to be made for implementation of DRC?
No, I think we both like to make the point, Paul, don't we, that actually at this moment in this baby's life is when they're going to have most team around them. So we've not had to make any additional staffing requirements. Generally, there'll be the consultant, the senior registrar, junior registrar, 1 or 2 nurses with this baby. And you find that most of them are just standing there with their arms around their back, because really you can only have 1 or 2 by this baby. So there seems to be an excess of people around. So we've never had a problem with that.
Now, some of the I guess the anecdotes that you had presented in the PowerPoint talked about a large gap between subsequent cuddles. Was this just coincidence with those particular babies, or is there, resistance on, we try to endeavor to give cuddles as soon as possible after admission. Is this also standard practice at your units?
Yeah, I think it's just even many units that are targeting regular kangaroo care. For whatever reason, it seems that Paul's got a really nice slide for some of his talks where he talks about the babies being shackled to their incubator because of this monitoring. So even with the best will, you find that it's often felt that the baby's too unstable for a cuddle, which isn't necessarily the case. I don't know, did you want to add anything, Paul, to that?
Yeah, only just to say, yeah, I mean, it's our great intention to get them out ASAP, but you can guarantee that things aren't as stable once they get on the neonatal unit, and that happens over days. So it's invariably days going into weeks for these tiniest babies still. So for example, that 22-weeker in the video you saw there, that mum didn't get her second ever cuddle until he was, I think, 45 days of age. And that's just very typical. Despite our best intentions, weeks pass by, which is a heartbreaking few weeks for parents.
Yeah, absolutely. And then I guess the last one I think in this category that was brought up by the audience, did you give mist or surfactants and or IV access prior to cuddles? Did you have the delivery room set up for some of these intensive care interventions?
So we don't practice that as a routine because the cuddle's generally only a few minutes. We've not delayed it. I think in the next couple of years we'll see prospective safety data for glucose in these babies who are getting cuddled. I know other centres around the UK who are doing it routinely, collecting all that. So we wouldn't do. I think those RCTs that are presented, they've done it differently. They've had IVs in place. If you look at our paper that was published, we do give that as an option, that IV lines can be put in situ. And I guess that will, in due course, allow for much longer cuddles. We foresee over years to come that the cuddle mate itself, the baby is likely to spend the first hour or two with its mother in the delivery room. I think that will happen in years to come.
Great. I think that was all from the environment and team resource perspective.
Thanks, Doug. So we are running out of time, but maybe just a question on breastfeeding. Have you found any difference in breastfeeding rates, or first expression?
Yeah, we've not formally looked at it, but the anecdotes we're seeing from the parents, from the feedback, are very positive in that it's encouraging and helping them to express and inspiring them to express. As you can see from that 22-week gestation mum who said that, it really was the difference in encouraging them to express. So I think we'll also see such data forthcoming in the next couple of years, showing it's having very beneficial effects on breastfeeding rate.
Yeah, and before I hand over to Alice, Alice had the question of preparing the parents. I think Paul did mention in his checklist that you had this conversation before during the antenatal counseling, I guess, to prepare them with that eventuality that you may not be able to offer in all cases. Yeah.
It's absolutely key, the preparation for parents. It's fundamental to the cuddle so that they know what to expect. And we go into detail in that in our paper. So I just want to say our paper is freely downloadable, thanks to the UEA that have paid for the open access. If you go into PubMed and type in delivery room cuddles, it'll be the first hit there. And we do go into some detail about the type of things we say in the counselling with parents about the cuddle.
Yeah. Paul, it's both Pauls. It's been very interesting, very intriguing. There are many questions, and I'm sure I can get in touch with any of you later to answer those questions.
Yeah.
It's been our pleasure, but I'll hand over to Alice to give you a vote of thanks.
Thanks, Atul. Absolutely, it has been a pleasure, and we thank you both for making time. We've watched Daybreak as you've been talking, so we certainly appreciate the early rise that you've both had and for your generosity in sharing the experiences, not just of your teams, but most importantly, families, as they've been on that journey with you. And that's really come through so strongly, that family voice and the experience of what you've been able to offer families. So thank you. We certainly will, I'm sure, tap on your shoulders again as we explore what we might be able to do here and how we can improve our temperature regulation, as a number of team members have alluded to. So thank you both, and we look forward to watching this space further and watching your team's output also.
Thank you. Thank you very much.
Thanks.
Thank you very much.
See you.
Thank you, Atul. Bye-bye now.
Goodbye.